Phones are replacing everything. I don't remember when I last put on the watch.
So you will sit there. Thank you so much once again for joining me on our first post-lockdown segment on the Social Protection Plaza. And indeed, this is our first chat on the plaza because of the lockdown, we couldn't get guests, we couldn't find people to talk to. But now with the opening, with the easing of the lockdown, we can have people who know about these particular issues that we're talking about to share their insights, to share their ideas. And today I'm very privileged to have the Executive Director of Save the Health Uganda to take us through health sector financing. You're welcome, Mr. Frederick Makaire.
Thank you, Gloria. Good afternoon, our viewers. I'm called Frederick Makaire. I am the Executive Director of Save for Health Uganda. I'm also an economist, health economist. Save for Health Uganda is a national NGO which is primarily promoting community health insurance, or generally trying to ease access to healthcare in this country. We've been around since 2002 and currently promoting community health insurance schemes in 9 districts of central Uganda and western. Yeah.
Okay, yeah, thank you so much. And I think you are probably the best person to be talking about being an economist and with a particular interest in health financing, but also someone who has actually been out in the field interacting with the community, understanding the challenges that people go through. I've been trying to think about the times that as a Ugandan, when you think about health, when you think about, we get to worry a lot about hospital bills. We get to worry a lot about, when you listen to radio, when you listen to television, when you read newspapers, there's going to be someone who is asking for support. So all these kind of health drives that we do, someone wants to have a procedure, surgery or something, it is always has to go back to the community and people asking for support. In your own perspective, how would you describe financing for the health sector in Uganda?
I think if I'm to use one word that represents the majority, I would say that it is a huge burden for the majority of the population in Uganda. Because actually looking at what government contributes to the financing currently, the budget keeps, in terms of proportion, keeps declining. Although in terms of money, there is some slight increase. But it's far, far, far below what we expected. According to the health sector development plan, we expect it to be about 15% of the budget. This year, 2020-2021, it has dropped to 6.2. Then the huge burden is actually on the individuals. The out-of-pocket payments has been increasing, and now the individuals are meeting about 42% of the budget. That is huge. That's huge. Then the donors come in also to provide about 40%. So basically, the huge burden is on the individuals. And that, by the way, is in an environment where healthcare is supposed to be free.
Yeah.
So it means a lot of people, instead, when they walk into the facility where they expect a free service, they end up paying for it. And then as a consequence, we see a lot of people who are suffering catastrophic expenditure. People who, after going to a hospital, when they get back home, they find poverty. Because while at the hospital, they had to make a phone call to sell something at home to be able to bring money, and they pay for the service. So that happens a lot. There are those who have become poor. There are those who have stayed longer in the hospital because they are detained. They couldn't find money to be discharged. All this is happening. And that is the way healthcare financing is currently in the country. And that is what is happening. And so interventions that could help the individuals are what needs to actually be promoted at the moment.
Yeah, you know, there's been the National Health Insurance Bill. I mean, one would say it is something that we would be prioritizing.
Yeah.
Because with an insurance scheme, you're sure that people are able to access health services, but then also quality health services. But we've seen the bill drag on and on for years. I mean, what would be your thoughts? Why is it something that is supposed to be priority is instead not prioritized?
In my view, probably two main issues stand out. First, there is this free healthcare policy that has been running and quite still popular.
Yeah.
Especially politically, it is still popular. So it has a lot of political will. So even while the debates of the national health insurance are going on, you don't hear anybody saying, okay, so we need to repeal this one and promote the other one. So it means that it is still very popular, but not only among the politicians, even in the community.
Yeah.
There are a lot of people who actually still think that free healthcare is the most viable way to finance, because they are poor, they don't have money, and they feel they are paying taxes, so these taxes should be seen in the kind of services they
But
get.
then isn't it also just an idea? Because in any case, when you go to the facility and you don't get the services that you deserve, is this actually free?
It isn't free. And of course, people are now beginning to realize that it's not free. It's not free, and actually they are paying a lot. But that's the mentality they have. But also when politicians go out, there is this tendency to blame, for example, the service providers, to say, oh, for us, we release the budget, but actually people are leaking out the money, and so we need to just tighten the and close the gaps so that leakages don't happen, and then we shall have sufficient services. There is that feeling.
Yeah.
The second issue, why we have over-delayed, in my opinion, is the low appreciation of insurance generally. And probably it comes from the past experiences, because in the past, people have complained that they used to buy insurance, but then getting a claim to be compensated used to be very difficult and tedious. So there is that mentality that insurance actually does not pay. And people have that. So when you try to talk to the public about insurance, there is always a direct and immediate rejection. Secondly, the concept itself of pooling, which is at the center of this insurance, it's not appreciated and not understood. A lot of Ugandans think, including our leaders, they think insurance is like a saving. That actually you contribute money, and if you don't fall sick, your money is somewhere there.
They should give it back to you.
So that's the perception.
But
that
then also, does that speak to the values we espouse as a population? Like, we do not look at supporting each other, because like you said, insurance really is about pooling resources. When one needs, they are able to access. I mean, if you don't need it, but there's still going to be someone who needs it. So is it just really about the value system?
I think largely because that principle of solidarity is still not strong. That's very clear, and it is strong in some aspects and very weak in others. For example, we are very, very strong in solidarity related issues of spending where we shall directly benefit. For example, if we are going to organize a wedding, we can easily mobilize resources because we know at the end of the day we shall be at the party. But now for healthcare, if we contribute money to treat you, it only benefits you. So there is resistance to this kind of solidarity, where the beneficiary is an individual. But if the beneficiary is all of us, then people are eager to contribute. I think that is where we see a big difference.
I think actually there was one of the contentious issues in the bill was who is going to pay for the poor. And then people are like, well, so there was a bit of a pull and push there. People don't want to pay. I mean, if either government takes that up, but
or they stay outside. And I think the people in the formal sector, that has been one of the sticking issues why they have opposed the bill. It wasn't clear from the onset how the people, the poor and indigents,
Yes.
would come on board. And so the people in the formal sector thought that it would be them to foot that bill. And you know, they are not many.
Yes, sir.
Yet the people who are needed are many.
But then also, Frederick, you could look at it from this way. If you, I mean, these people that we are talking about as the poor, sometimes they're actually on our chain, or they are my cousin, my relative, somehow they are related to you. So eventually this burden comes back to you, because they're going to call you and say, well, your cousin somewhere needs help, your cousin. So it still comes back to you. So I tend to think there is still a lack of appreciation that, you know, at the end of the day, this burden is still coming back to me.
I think you are very right, Gloria. The issue, and for me I always tell people that the main issue that this country needs, if we are going to successfully introduce a national health insurance, which is a good solution to everybody, is to intensify health insurance education. I think until people appreciate that actually this huge burden is on us, and they appreciate that if everybody contributes something small and we have a big pool, it is for the benefit of all of us, it won't happen, and people will continue resisting, and people will continue spending those huge amounts to support their relatives and families. And I assure you, actually, you are very right to say that the majority of us are footing a lot of bills, spending a lot of money monthly to support our relatives and friends to clear medical bills. Yes. And so people just need to be educated that actually that can reduce significantly by just enrolling into an insurance system. It might be a national one, it could be another kind of insurance, but that will bring down the cost, because then we are going to spread the risk amongst many people than accumulating the risk on you alone. And that is what is not known. That is what the ministry has not done to get people appreciate and understand insurance so that there is buy-in. Because each time they talk about it, it's quickly rejected, misunderstood, and shelved. And that is always the cycle. It is now almost 20 years since the discussions started. And it's very unfortunate. In the region here, it's only Uganda and South Sudan that do not have a national insurance scheme. And South Sudan is recent. It's a very new country.
Yes, it is.
So we couldn't be at the same level like South Sudan. But I think with the way other countries in the region have moved, we may not be surprised soon to hear that South Sudan has a national scheme and Uganda is still discussing the scheme. And so I think at one point there is need to have concerted efforts by the ministry and other ministries and all stakeholders to educate the population. Of course, it is good to go into something which the population understands.
Yes, exactly.
And I think that's the advantage Uganda should be looking for and looking at. That the delay, we should not have taken 20 years to introduce a scheme, but introduce it like people who took only 1 year, when the population is as ignorant as, people thinking insurance premium is a tax. And these are the issues that people are talking about.
So maybe let's talk about I know you hinted on it briefly in the introduction, the Save for Health model. How does it work?
So Save for Health is basically promoting community health insurance. These are private insurances because they are public insurances and then private. Ours are private. They are also voluntary, not mandatory. So what happens among the voluntary community insurance schemes, we have 3 models. One of them is called member managed model. That's one of SHU's model that we are promoting. Here, the community members themselves are playing a significant role in the management of the scheme. So enrollment into the scheme is voluntary, but the members themselves are playing the role of educating their colleagues, of collecting the premiums and managing these premiums. They also play a role in contracting service providers and engaging them. In fact, once the service contract is signed, their members, when they access services, the bills are sent to the scheme and the members do the verification and then authorize payment. So they actually play like 80% of the roles themselves. That's why it's called member managed. And that's what we do in Luwero, Nakaseke, Nakasongola, Mitiana. That is the model we do.
How many people do you have now?
In that model alone, we have about 25,000 people currently active. But we also have another model which we call third-party managed model, where another body like Save for Health Uganda, we assist in the management of the scheme. So we have the community this side which is contributing money, and then the service providers that are giving the service, and we do the management of the fund. So we coordinate these two, link them up, and then when these people have access services, they build the fund, and we do the role of managing the fund.
Oh, so you work like fund managers.
Fund managers,
okay.
Yes. That's what we refer to as the third party. But the role is purely for fund management. Then the third one is what we call the provider managed model. These are the schemes you find at the hospital. The hospital itself is running a community health insurance scheme.
Okay.
And so some of the hospital staff are actually receiving premiums from users, and then they keep the money in the hospital. When people come to be treated, they pick money from that fund and treat them. So that is how it works, the three models. But SHU, largely, we are promoting the member managed model, where people are actually participating a lot in all the levels of decision making.
So do you actually determine how much someone contributes to the scheme, or this is still determined by the members?
No, this is one of the technical roles that we are still providing, but we have built capacity now.
Okay.
What we did initially, every community insurance scheme operates at a parish level. A parish, not a church parish, but an administrative parish. About 7 villages making one parish. So in each parish we have one scheme, community health insurance scheme. So initially, each of these was an independent scheme, and of course they were collecting little money, and therefore the pool was little. And by the time they finance half the bills, the funds would be depleted. So what we've done is to federate these parish-based schemes into one regional scheme.
Oh, okay.
So now instead of having 150 different schemes, now we have 4 big schemes. So in Luwero, Nakaseke, Nakasongola, we now have one scheme. And that one scheme now brings together about 110 parish-based schemes.
Okay.
And it brings together about 22,000 people who are active now. Now, once this federation happened, we created a secretariat which now manages all the sub-schemes into one, and even the pooling moved from the parish to a region. So instead of pooling at a parish, now they pool at a region. And that has helped to actually increase the benefit, because prior a bill would be covered probably up to 100,000 per episode. When they pooled at a region, now they are able to cover up to 400,000 per episode. And the number of episodes are not limited. So one member could fall sick 10 times a year.
It doesn't matter how often you fall sick.
It doesn't matter.
Okay.
The only condition is the cap.
Okay.
Each time you are going there,
It's
you cannot exceed 400,000.
Okay.
But you can go weekly, you can go monthly, as long as you are genuinely sick. And of course, we have put a small co-payment to deter people who just want to go and test the system and abuse, because we also have those kind of people who really don't believe that they can pay 10,000 and access benefits of a service of 500,000.
Oh, so just on that bit, how much do people pay? Is it monthly? Is it weekly?
In our case, people pay annually.
Oh, okay.
Annually. So we charge the cheapest premium is 10,000, and that is per head per year. But we also have people who are paying 15,000, 20,000. The highest premium in our case is 50,000 per head per year. But the 50 is for the corporate groups in our districts. People who are in formal employment, people who are in urban settings, these ones can pay 50. And the reason they pay 50 is because we have put them on a biometric system. So they use the fingerprint, and they have a biometric card. But the other ones who are paying 10, 20, they use a paper card, and so the system is very analog, and also their capacity to pay is too low. So that's the difference. But the premium is very low, 10,000. So they contribute
10,000 for a year.
For a year per head.
Okay.
Yeah, but of course we encourage the entire family to join. So if a family has 7 people, they will pay 70. If they are 10, they will pay 100. So once you choose to be part of the scheme, then you bring the entire family on board.
So it is not transferable. If, for instance, it's me who has been contributing that 10,000, I cannot say, okay, my child can benefit of that. So the child should also be paid for
exactly
differently.
Every person,
yes,
there is a premium
okay.
on every person. So even if the child was born today, if you want them on the scheme, you pay. In fact, we even encourage pregnant women to pay for the pregnancy, especially if they expect that they will deliver during the year.
Okay.
So because if you give birth, you, the mother, you will be on insurance, but the child will not be on insurance. So what other people do, they register the pregnancy and they pay the premium, so that at birth, this child automatically becomes a member of the scheme. So the principle is that everybody who is on the scheme must have a premium on their head before they access the benefits.
Okay.
Yeah.
So, I mean, it's been how many years, Save for Health now?
About 20 years.
About 20 years.
Yeah.
Do you think that actually that provides us with some kind of a model that we can use for, or maybe how does this fit in the national health insurance scheme debate?
Actually, it fits quite well, especially when we are talking about the people in the informal sector. People in the informal sector, how they will enroll and be part of the national health insurance. You see, the previous bills, before the 2019 bill, which is before Parliament right now, but the previous bills, 2014, 15, 16, the emphasis was always on the formally employed.
Yeah.
And the argument why they wanted to start with those in the formal employment was always that the people in the informal sector, first of all, nobody knows who they are. Yes. Nobody knows what they earn. Nobody knows how to reach them.
Yes.
So that was a tricky way, a very wise way of saying, no, let's start with these ones that we know.
It is really an excuse I still fail to understand. If you're going to tell me that the informal sector contributes this percentage of GDP, how are you able to actually come up to that figure if you can't trace them?
Maybe it's a guess. We can't tell. But actually, we expected that URA would have this figure and this information. But indeed, they don't, because most people in the informal sector don't even pay tax. In Luwero area, Nakasongo and Nakaseke, where we work a lot, we have people with huge farms, for example. They are not paying tax. There are people with businesses there on the ground, but they are not taxed the way someone here who is formally employed, even if you are earning 500,000, 300, 400, you will be taxed. Those people in the informal sector don't. So the community health insurance schemes provide a very important opportunity for the NHIS to reach these kind of people, because that's where they work best.
Yes.
The systems are informal. Like I told you earlier, the leaders who are entrusted with the role of registering members, collecting premiums, are the people who are staying with these ones in the community. So they know relatively how much each one of them earns.
Exactly.
They know who cannot afford a premium, and they know who is rich amongst themselves. So this, for us, we have tapped into this, and we think the NHIS can tap into that as well. Because from Kampala, there is no way you will get a premium in some village in Nakaseke or Luwero. Yet people on the ground, with the structures of the community insurances, they are able to go house to house, collect a premium there, and then they remit it. They even bank it on their own. So we think that model, the NHIS needs to take advantage of that to reach the entire population, especially in the informal sector. There is, of course, the informal sector in the urban.
Yes.
Like Kampala, Wachiso, these people are organized a little in Kasita and other. But the informal in the rural, they don't even have any associations or also no leadership structure. So this is where the community insurances can actually play a big role. And we took one other step forward to demonstrate to the NHIS that this model needs to be considered. Together with the Luwero District local government, in 2018, we developed an ordinance. So the district council developed an ordinance which was bringing into place a mandatory community health insurance scheme for the entire district. And that was mandatory community health insurance. So basically every resident in Luwero district would be enrolled into this scheme with our differences there. Some of the people are in formal employment, others are in informal. We have students, we have everything there. So the idea was that we were going to use the structures of the administration structures, the scheme structures, the church structures, and all those kind of different structures. And we term each of these structures a community. And then we use them to turn each of these communities into a scheme, a community insurance scheme, where people would register, pay their contribution, and then pass it over into the district pool. And that model is well defined in that ordinance. And we think that if that had been allowed to be piloted, this would have given an opportunity to the NHIS.
Oh, the pilot did not happen?
It didn't happen because when the bill, the ordinance was presented to the Solicitor General, the ministry also at that point tabled the NHIS bill. So when the Solicitor General discovered that the NHIS had reached Parliament, they wrote back saying, okay, now what you people in Luwero wanted to achieve will be achieved in the NHIS. Unfortunately, last year we had, of course, disturbing news that the president had asked them to withdraw the bill and wait. So I think that dilemma now goes back to where we started, and yet if the Luwero ordinance had been allowed, it would have been a very good pilot to give lessons to the NHIS, and probably it would have been easier to replicate a model that has been tested than to wait and then start implementing when we have not demonstrated anywhere.
Yeah, because really that's where the challenge usually is. You're not going to pick something from somewhere else and then want to replicate it here, because contexts are totally different. And now for this, we are going to have something that is tested in our own context. So probably it would have been easier to replicate elsewhere. But well, maybe issues of public policy can be a bit you never understand what the interests are, what the ideas are, and of course the institutions, so it gets a bit challenging. But then I think for COVID-19, when you look at, one would say there's been a lot of interest in the health sector. We've seen quite some monies going towards the health sector. But then, of course, for people like you who actually are stakeholders in this particular sector, you would appreciate that actually there's been a lot of gaps. A lot of issues are not being catered for. It seems like one would say there's a presumption that the other public health issues are on a lockdown. People are not, but yet people actually still, in the communities that you work in, what has been their experience during this period when there's been a lot of focus on one particular area?
Well, I think the experiences are quite many. Others are disturbing, but as you rightly put, everything centered towards health. And most of the other sectors seemed not to function at all. For me, the experiences I've had, most of them are really very experiences that are negative on the part of the families. We had in the scheme, for example, for us in the community insurance scheme, people had their insurance cards, for example. So they know that they don't have to pay when they go to the hospital. So they don't worry about medical bills, and they know access is easy. But the moment public transport was cut, they became like people who didn't have insurance. There was no difference anymore. Because card or no card, you needed first to look for the RDC to get permission. And the people didn't know. In fact, what COVID helped, one positive thing that I've seen with COVID is that the office of the RDC eventually came to the light and people got to know the contact of the RDC and to know them physically. Many people didn't even know whether the RDC. But now everybody was obliged to look for the RDC. But it was not easy for the people in the rural areas. It was very, very difficult. So most of them tried to go through the LCs and then they would be actually beaten up on the road if they didn't have the permission from the RDC. So we got people who were on insurance but could not use the service. And that was very difficult on our part because our main objective is to simplify access. And here people were sick and could not access. We had people who were delivering from home. And a number of some women could actually, we have 2 examples of women who delivered at night at home. They tried to get permission, they couldn't find transport. And one lady bled to death and another one lost a child. These examples are there in the communities. Those are the effects, direct effects of COVID and the consequent, the lockdowns that came after. But the other big challenge that people have faced was many of our people that we target in the informal sector, most of them were market vendors, so they didn't have access to income anymore. Some of them were shopkeepers. So marketing and selling their products became a problem. So they had no income, and so they tried to shift in such a short time to shift to farming and other activities, but of course these take a long time. So the coping strategies were very difficult, not easy for them, and we are yet to assess the actual impact, but we hope people didn't have to sell their assets to be able to survive, especially those who had who move with their capital, like these market vendors, people who are going to sell clothes and all these things. They stayed with their products, and we don't know what has happened to them, but that is the experiences have not been the best. Yeah.
So going forward, well, they have stopped us from saying we're going to have a post-COVID. Well, apparently we might, until we actually get a vaccine, we're probably having to live with this coronavirus.
Yeah.
But so as we plan to live with the virus, when it comes to issues of health sector financing, what should be our way forward? What should we be looking at?
I think one of the things that we need to look at, generally speaking, even after, as you said, post-COVID, or one of the things is to clearly come out with a health financing strategy for this country. I think until now, most of us are confused on the direction that we want to take for financing healthcare. We still have this free healthcare policy, which is largely tax funded.
Yeah.
And then we have, of course, donor funding, we have out-of-pocket funding. This direction, of course, is not sustainable for most of our people who are financing a huge part of the budget. There is also a plan to finance through these insurance mechanisms, approaches, which we believe would be the best way to go. Financing using the insurance mechanisms. I think the dilemma we still have is to clearly come up and say this is the direction we are taking, so that we rally around that strategy and try to make it work. We cannot succeed and move forward if we are going to continue having both. And yet we know that people will not accept to prepay in a mechanism of insurance when we still have a tax-funded system. That is one way forward that we need to agree on and pursue one strategy. Secondly, whatever strategy we choose, government needs to put more money in the sector. I think literally COVID has shown that when we had the crisis, it is the general public still that came at the rescue of the country. We have been taking donations and everything, vehicles, blankets, literally everything.
Well, they told us we are in this together, so.
Yeah, but that shows you that we are not ready for any emergency. If we have another health emergency,
Yeah.
next time what will happen? Are we still going to call out people to bring and we fundraise? So I think going forward we need to strengthen the system, the healthcare system, and one way to strengthen it is to have a robust system where we can finance the sector.
Yeah.
And I think we need government to commit more resources. I know that the communities are going to continue funding,
Yes.
but government needs to fund more. We shouldn't have a scenario like currently where we fund more and government funds less. It should be the opposite. And all our funding as private citizens need to be done through health insurance, not directly out of pocket each time we encounter the system. This is catastrophic, of course. So we need to organize how we pay, how we support the system by putting money in advance in an insurance, and then we know that all the money we have contributed in insurance will eventually go to support the sector, the health system. But at least it is an organized way. We have put equity into it. People who earn more are putting a little more.
Yeah.
Those who earn less are putting according to what they can afford.
Subsidizing.
Yes. Currently the system is very unfair, that the poor are actually putting a lot more and the rich are putting less, because the rich and those in formal employment, they have some form of insurance. Some are employer based, some are private, but at least for them they pay once in an insurance. The poor are going and paying every time they are falling sick, and the disease burden is still huge. So most people are working to finance the health sector. So we need to organize that, and then we make sure that government is contributing more, and what we, the private people, are contributing is contributed through the insurance. That is the second thing. The third aspect we need to focus on is to concentrate on efficiency of whatever money we have, including what currently government puts. Because if we were efficient, what government is allocating to the health sector is also not small. It is a lot of money. So if we were using it efficiently and prioritizing properly, probably that money would do a lot than we even see today. One of the areas we need to prioritize, and COVID has demonstrated that, is prevention. Because that has been the strategy of this COVID fight in the country. The president was very clear that we cannot afford to have an outbreak. So the best strategy is to prevent the occurrence or the outbreak of COVID. And so we were told to lock down, we were told to do all these preventive measures, nutrition and all these hygiene and all these things. I think that should not stop with COVID.
Yeah.
We need to continue with that approach, because prevention is cheaper than actually trying to treat diseases. Disease treatment and management is very much more expensive, because you need to build the hospitals, you have to have a lot of workers, you have to have beds and all. Yet prevention, each one of us can manage in our own spaces at home and different areas. So I think that should need to become one of the priority areas. Prevention and then health promotion. Because if you have seen our response to COVID, these have been the main strategies. Exercise, stay home, do all this to promote health, but also prevent. Social distancing, hygiene, eat well, and all these are meant to make sure that we are promoting health and also preventing the disease. And I think going forward, that needs to be the same direction we emphasize, and shift the Ministry of Health focus from treating diseases and actually more into promoting health and preventing diseases. In that way, I feel that whatever resources we have currently, we might actually find that we do a lot with it, and then we, of course, advocate government to add a little bit more. And then for us who are paying into the system, let it be an organized way of payment. Because if we don't organize it, people are going to continue paying under the table, and that's very expensive.
Yes.
Then they continue to pay each time they go to the health facility. That's also catastrophic. Yeah.
Okay, thank you so much, Frederick.
You're welcome.
This has been very insightful, and well, I hope we do it once again.
Thank you so much
Yeah,
for the opportunity to share. Yeah.
Yes, thank you. That is it really from us on this segment of the Social Protection Plaza. And to remind you, really, social protection is really about interventions, policies, and strategies that are put in place to ensure that people are not vulnerable. They're not vulnerable to poverty or vulnerable to shocks like we've had the COVID-19 shock. So health insurance is core, because here we know we have, like our guest has elaborated, we have a very huge out-of-pocket expenditure. So a lot of Ugandans are struggling with health costs, with health bills. So if we had a scheme in place, we would be able to ensure that actually our people have access to quality health services whenever and wherever they need them. Thank you so much, and I hope we meet next time.
Thank you.
Okay, thank you.
Wow.
Exactly 40 minutes.
Really?
Yeah.
And it's not a lot of